everyone. Thank you for joining for this teaching today. As you can all see, the topic today for the presentation is pelvic inflammatory disease. One of the common topics that we come across in the community as a GP, as well as in the hospital setting, we do see a lot of people coming with pelvic inflammatory disease, and some of them getting admitted, hence the relevance. It's quite a basic topic, and most of the things are just what everybody already knows, essentially, but it's kind of a refresher, if you may. So the first slide, just trying to go next. So pelvic inflammatory disease is essentially the inflammation of the upper female genital tract that results from the infection descending from the endocervix upwards, causing endometritis, salpingitis, parametritis, oophoitis, tubo-ovarian abscesses, and or pelvic peritonitis. Any of these, depending on where the infection is, or any combination of these, comes under the umbrella of pelvic inflammatory diseases. By far, the most common pathogens involved in the pathogenesis are Neisseria gonorrhoeae and Chlamydia trachomatis, accounting for about a quarter of cases in the UK. Apart from it, Gardnerella, vaginalis, anaerobes, and other organisms found in the vagina likely can play a role. Mycoplasma genitalium is another organism which has been associated with the upper female genital tracts and is very likely cause of PID as well. The risk factors, any instrumentation of the uterus, one of the most common things is intrauterine devices, which increases the risk of developing PID, but only for about 4 to 6 weeks after the insertion. And this risk is probably higher in women who already have a pre-existing infection like gonorrhea and trachomatis. Apart from this, other risk factors include menstruating teens, by far the largest population who come and present with PID is less than 25 years females, and particularly those who are in their teens. Multiple sexual partners, previous history of the pelvic inflammatory disease or STIs, unprotected intercourse, again, one of the risk factors. There are some associations. The link is not very clearly understood, but of course there's a strong association in the studies, including bacterial vaginosis, female douching, smoking, which is thought to affect the cilia of the fallopian tubes, causing dysfunctional cilia and hence getting infections quite easy, and substance abuse as well. Just taking a bit longer to go next. Okay. The symptoms, most of the times, the most common picture is a lower abdominal pain, typically bilateral, but this can again be unilateral depending on where the infection is. If it's localized as an abscess on one side, then the pain would be on one side, but most of the times it's a low abdominal pain, typically bilateral. Sexual intercourse is really painful, so deep dyspareunia, abnormal vaginal bleeding, including postcoital intermenstrual bleeding, and menorrhagia. Secondary dysmenorrhea and abnormal vaginal or cervical discharge, which is often offensive or purulent. One of the very specific term, Fitzhugh-Curtis syndrome, which comprises of the right upper quadrant pain. It's one of the complications of PID and can present as right upper quadrant pain because of the inflammation around the hepatic capsule and formation of adhesions around the liver or parahepatitis. In women who are HIV positive or we got HIV/AIDS, the symptoms appear to be more severe, but the treatment remains the same, and the response to treatment is same in women who have got HIV. So signs to look for in the clinical examination: low abdominal tenderness, usually bilateral, but again it can be unilateral depending on where the disease is. If it's one-sided abscess, so it can be unilateral. Again, adnexal tenderness. There can be a palpable mass as well if the abscess or hydrosalpinx is big enough to be palpated. Cervical motion tenderness, one of the typical features, but again, it's not always present, and pyrexia. So complications, PID remains an important disease because of the long-term sequelae that it has, given if the disease is not treated early on. So most common Complications include infertility, tube-ovarian abscesses, ectopic pregnancy, chronic pelvic pain, peritonitis, especially pelvic peritonitis, Fitzhugh-Curtis syndrome that we mentioned in one of the previous slides, intestinal obstruction, though less common, quite rare, but can lead to, if there's a local spread of the disease, if there's a ruptured abscess, if there's formation of adhesions, all of these can put risk for intestinal obstruction, and systemic infections like sepsis or disseminated infections like endocarditis, gonococcal arthritis, meningitis. So different diagnoses to include in this case is ectopic pregnancy. Of course, a pregnancy test is the important tool to rule out a pregnancy. Acute appendicitis, which most of the times present with nausea and vomiting as well, as compared to 50% cases of PID who do present with nausea and vomiting. So it's more common in acute appendicitis. Also, about 15 to 20% of the cases with acute appendicitis can have cervical motion tenderness as well. Hence, important diagnosis and careful history taking is important. Endometriosis, the link of the symptoms with menstrual bleeding can again hint towards a possible diagnosis of endometriosis. Ovarian cyst, torsion, or rupture. The symptoms of the onset of symptoms usually sudden and severe as compared to a few days and gradual onset in case of PID. Urinary tract infection can usually present with other symptoms like dysuria, increased urinary frequency. Irritable bowel syndrome, usually the history is quite prolonged over a long period of time, change in the bowel habits over a long period of time, and functional pain in absence of any identifiable organic cause. So investigations that we routinely do include a uterine pregnancy test. Of course, we want to rule out ectopic pregnancy. Full blood count CRP may or may not be needed, depending on the clinical picture. Swabs, a charcoal swab, a high vaginal swab for trichomonas and BV, and a pink endocervical swab for chlamydia and gonorrhea. So where a gonorrhea test is needed, it should be specifically requested on the form, but there's no need for a third or a separate charcoal swab from the endocervix for this purpose. Imaging, the role of imaging is quite limited. It's not routinely done, it's not routinely advised, and it's not needed, but it can be helpful if the abscess or hydrosalpinx is being suspected. If an advanced imaging is needed in a chronic disease or clinically, the picture suggests that an MRI or CT scan is needed, then MRI is really preferable since the risk for exposure to ionizing radiations is not there in the reproductive age. Diagnosis, of course, a positive test for gonorrhea, chlamydia, or mycoplasma genitalium supposed to diagnosis, but the absence of these infections does not necessarily rule out PID because the other organisms as well, and testing for all three organisms is, however, recommended. An elevated ESR, CRP indicating inflammatory process in the body is a supportive but not a specific investigation. The absence of endocervical or vaginal pus cells on the smears from the vaginal swabs has a good negative predictive value. The absence of them can rule out PID for diagnosis, but their presence is a non-specific and has got a poor positive predictive value. So coming to the management part of it, of course, delaying the treatment increases the risk of the long-term complications, and hence it's important to have a low threshold for the empirical treatment of a PID. A broad spectrum antibiotics is usually required to cover a wide range of aerobic and anaerobic pathogens commonly isolated from the upper genital tract in women with PID. And the decision to remove the IUD needs to be balanced against risk of the pregnancy, especially women who have had unprotected sex in the last 7 days. And in those cases, hormonal emergency contraception can be appropriate. So the antibiotic regimen, this is directly taken from the TRUST guideline. Of course, there are more alternatives on the BASH guidelines. which is again where most of the information for this presentation is taken. So this is from the trust guideline. As we all can see, there's a standard treatment and the penicillin allergy treatment. So IV antibiotics are recommended for patients with more severe clinical picture. For example, signs of sepsis, pyrexia, clinical signs of tube-ovarian abscesses, signs of pelvic peritonitis, and we can add to this PID in pregnancy as well. So ceftriaxone 2 grams IV stat and IV or oral doxycycline, and then followed by doxy and metro, and then in case of penicillin allergy, clindamycin and gentamicin, followed by doxy and metro. Outpatient regimen is the most commonly that we use in EGU or in the community, includes intramuscular ceftriaxone 1 gram single dose, and then doxycycline and metronidazole for extra anaerobic cover for 14 days, and then remains the same for penicillin allergy. And in case of anaphylaxis, ceftriaxone can be replaced with azithromycin 2 grams. Of course, there are more alternatives, and they can be found on BASH guidelines as well. So the general advice is, if the disease is quite severe, the rest is advised. An appropriate analgesia, of course, is important, and if needed, something stronger can be prescribed. Advised to avoid intercourse until the patient and their partners have completed their treatment. Patient information leaflets can be important here to make the patient aware of their long-term sequelae and the importance of testing and partner tracing. So these leaflets are available on BASH and RCOG websites. Surgical management. So the role of surgeries is again, we can say the last resort for the treatment of PID, and it depends on the consultant and the senior decision whether they want to go for it. So laparoscopy may help early resolution of the severe disease by dividing adhesions and draining pelvic abscesses, but ultrasound guided aspiration of a pelvic abscess is less invasive and may be equally effective. Laparotomy may be required to assess and treat clinically severe pelvic infections, and it is possible to perform adhesiolysis in cases of perihepatitis and Fitzhugh-Curtis syndrome, but there is no evidence whether this is superior to only using antibiotic therapy. So, and again, quite important that current male partners should be contacted and offered screening for gonorrhea and chlamydia. For this, often a referral to sexual health clinic and gum clinic is sufficient. Other recent sexual partners may also be offered screening, and tracing of the contacts over the last 6 months is recommended, but again, it is subject to the sexual history. Broad spectrum empirical therapy should also be offered to male partners, that is a doxycycline twice daily for 1 week, and again advised to avoid intercourse until they and the partners have been treated fully. So for the follow-up, review at 72 hours is recommended with moderate to severe symptoms or signs, and failure to improve suggests there's a need of further investigation, IV therapy, or surgical intervention. Further review in the clinic or either by phone. Again, this is something to be done in the community, in the sexual health clinics, in the GP surgeries. 2 to 4 weeks after the therapy is recommended to assess the compliance, progress to the disease, and repeat testing as appropriate. Yearly for chlamydia is 3 to 5 weeks repeat testing, and for gonorrhea 4 weeks time. So yeah, that brings me to the end of the presentation. If there are any questions, any comment, any feedback, please let me know. And again, I'd like to take this opportunity to thank all the people who joined today, as well as a general thanks on behalf of all the GP trainees to the entire Gynae and Obs department, as we are ending to rotation, and I think all the support that we received during this 6 months, and I speak for all the GP trainees, that has been phenomenal, and I would like to thank everybody for that. So yeah, if anybody has got a question, feedback, anything, please do not forget to fill the feedback form as well.
Thank you very much, Bahadur. Right, I'm going to stop the recording in case anyone wants to ask some questions or There we go.